Hi, Katie. Thank you so much. Hi, everyone. It is so great to be with you all. My name is Katie League. I am the Behavioral Health Manager at the National Healthcare for the Homeless Council. I am based in Baltimore, Maryland. I am a clinical social worker. And I spend the majority of my time at the National Healthcare for the Homeless Council. I also work embedded within our local healthcare for the homeless here in Baltimore, Maryland, specifically most recently working with their street medicine team. I had been employed there for almost a decade just prior to joining the council, where I served as the director of community services, which I oversaw our mobile clinic and our street outreach. And so I have direct knowledge of the healthcare for the homeless here in Baltimore. One of the great things, I've been with the council now for 5 years. And one of the great things about the council, the things that I love most about my job, is I get to learn about healthcare for the homeless across the country and get to lift up their best practices, get to tell you all about what they look like. One of the things that before I joined the council, I had always heard, well, if you've seen one Healthcare for the Homeless project, you've seen one Healthcare for the Homeless project. And I didn't really know what that meant until I lived it and got the chance to start to see different HCHs and recognize that they are deeply different within each community because they are responding to the needs of their community and they are structured within their ecosystem there. So within their homeless service system, within their healthcare system. I often say that healthcare for the homeless are in the middle of the Venn diagram of homeless services and healthcare, primary healthcare. That is generally where we reside. But the excuse me, the values and the service delivery is modeled in a way that, in a lot of ways, when you go into any program and the staff and the organizations and the values that those programs hold and the ways in which they serve their clients are very similar. So while they are modeled differently and they look very different across the country, there are lots of core values that are really similar today. So we are going to talk quite a bit about that in our time together. And then the best of all, you're going to hear all about a specific program so you can learn from the best. So as I said, I work for the National Healthcare for the Homeless Council, which is a member organization. There are healthcare for the homeless projects across the country. There are almost 300 of them. And as I said, they look very different. These include medical respite programs. They include freestanding, federally qualified health centers that serve exclusively individuals experiencing homelessness. That's what we look like here in Baltimore. There are others where there is a healthcare for the homeless team that is embedded within a larger federally qualified health center or a hospital system. So they do really look very different. There are mobile clinics. There are street medicine programs. They do lots of different types of service delivery, but really they are focused about meeting people where they are. We at the council, as I said, really get that opportunity to learn from all of you and to lift up the best practices that are happening across the country. And we do this through bringing these groups together, healthcare professionals, medical respite providers, and most importantly, people with lived expertise. One of the things that is most important in the healthcare for the homeless model is the consumer advisory existence on boards, and the ways in which they should be informing local practices. So we have the great opportunity to provide that training and technical assistance. We have a research arm that focuses on applied research, and then most importantly, uplifting the voices of those experiencing homelessness. So lots of opportunities. One thing that I do really like to draw your attention to, especially in a community that it has many HCHs, is to know that we do have a free online learning, it's called an LMS, a learning management system, that is available entirely free. They are kind of self-paced courses that are actually, there's a Healthcare for the Homeless 101, that's a whole curriculum, and then many individual courses. Really great ways, especially if you have new staff or you have new individuals who are moving from one role to the other within your organization, and you want to try and get some of the spirit and the values and the core principles of what it means to be a healthcare for the homeless and what it means to serve our people. They can be a really great way to do that. As I said, they are free and available to anyone. We also have an annual conference This year, we are going down to Orlando, Florida, and many of the materials from that conference are also available free of charge on our website. So you can look at past ones now. The conference doesn't happen until June, but you'll see that again in the future. So hopefully, some really great learning resources for you all that are all free of cost, because really our goal is just to bring together people and the opportunity to learn from one another. So most, just like what you all do here in creating this learning community, it is so essential. So often people are doing really great, innovative things that we can all just learn from one another. And thank you so much. I see a little shout out for the trauma informed care webinars series. We have all sorts of things that are available there. So we definitely hope that you are able to take advantage of them. So, knowing that you all probably have a basis in this, but I do just kind of want to ground our work and thinking about who we are as health centers, and recognition, because we're gonna, as I said, Healthcare for the Homeless projects fall within the larger health center continuum. So, but recognizing that health centers serve 1 in 9 children and 1 in 10 adults nationwide. We are everywhere. We are in your community. You all are embedded within your communities. These are invaluable parts of community systems. Um, and that there are nearly 1,400 health centers and 15,000 service sites. And I think this is one of the first things that is certainly really important, that we in the Healthcare for the Homeless model is that our health centers often provide services at a variety of sites, not just one site base, although very often there's kind of at least one kind of main hub or fixed site, but that really the essence of the model is to going where people are and trying to bring services into the community where they are not. And so that is really essential within the HCH model. It is not unique to us, but it is something that I believe that Healthcare for the Homeless programs do really, really well and really focus on trying to think of who's accessing their services and making sure that they're providing the best comprehensive care to them, but also who is not accessing their services and why, and how can we continually chip away at that number of individuals that are not accessing care, particularly among those who would like to, but there's some barrier in the process, whether it be geographic or it be workflows that make it so it is difficult for them to access. And more than 32 million people are served by health centers. This is from the 2023 data. Everything's always delayed in getting it, but really important to recognize we are everywhere. You all are essential to the overall health and well-being of our communities. And so also an opportunity for me to express my gratitude to you all for being embedded and serving your communities in such effective ways. So federally qualified health centers, as I said, are kind of in this HHS. I don't want to get into the too big of the umbrella. We don't need to get too weedy into this. But the designation for Healthcare for the Homeless is in for the Section 330 of the Public Health Services Act. And so 330H, very convenient, homelessness, H, easiest way to remember it for me after all these years of working in it, that is the designation for programs that receive Healthcare for the Homeless funding. So you do not have to receive Healthcare for the Homeless funding to serve individuals experiencing homelessness. In fact, I venture to guess that every single federally qualified health center serves individuals who would meet one of the many definitions of homelessness within our federal government. We at HCHs get to take the broadest definition, which certainly includes individuals who are unhoused, living on the streets, living in shelters, but also those who are doubling up, couch surfing. All of those are individuals who are eligible to receive care under the HCH grant. And the great thing about HCH grants are for the health center's perspective, it qualifies for that enhanced reimbursement from both Medicare and Medicaid. And they are designed, these are, HRSA has called them special populations. So individuals experiencing homelessness are one of those special populations. They offer a sliding scale fee. Health centers do. Healthcare for the Homeless projects are able to slide all the way down to zero. Another thing that makes us unique and really wonderful. And that there is ongoing quality assurance programs. They are highly, highly regulated health centers. You all know if you are living within the worlds of HRSA regulations, you are probably regulated by multiple entities. I know in Baltimore, we were Joint Commission certified. We were Patient Centered Medical Home certified. So lots of different accrediting bodies, meaning they are highly scrutinized, but also means that they are providing incredible, comprehensive care to the individuals they serve. A really cool thing about federally qualified health centers is that they have a governing board of directors with 51% supposed to be represented by patients. And that the idea is that we as federally qualified health centers provide comprehensive care. So not just primary care, but in the preventative healthcare space, but also have some plan either directly or in an arrangement through collaboration and referrals to provide dental, mental health, case management, transportation services, hospital and specialty care. The list goes on and on of the services that federally qualified health centers either provide directly or do in partnership. So HCH is specifically, as I said, that's that 330H funding designation. And very often health centers receive a variety of 330 funding streams. So if H is one of them, that is the Healthcare for the Homeless program designation. There are 298 HCH health centers across the country. And in 2023, the most recent data we have, 48 health centers received HCH alone, what we call an HCH standalone funding. So they are not a larger federally qualified health center that receives other 330E services, funding streams, but they serve exclusively individuals experiencing homelessness. So some of the great things that have happened as of now, 8.7% of new health center funding must be an HCH designation, and that to be an HCH, we do not have to have the 51% consumer majority board, although every HCH does have consumer representation on their board. It is an incredibly important part of the way in which the HCH model really roots the work by being informed by the people who not just have, but are currently receiving care from that health center or from the health system. It is essential. People closest to the problem are also those closest to the solution. So they are essential in informing how we structure, how we modify, how we practice. HCHs also always have integrated behavioral health services, again, whether that be directly on site, which is typically the way it is offered. They also do a ton of outreach. And as I said, this is really about engaging the people who are within our service area. So HCHs have always been rooted, and actually the initial movement before there was such thing as a HCH designation was rooted really in outreach partnerships, primarily with nurses and peers or nurses and social workers, is the root of the HCH movement. So we know that there is a higher prevalence of physical illness, psychiatric disease, and substance use among individuals experiencing homelessness. There's a lot of reasons for this. They can both be the thing that caused the individual's homelessness, increased medical expenses, or a sudden loss of employment due to one of these health conditions can cause somebody to lose their stable housing. It can also be a result of being homeless as a means of having been either a victim of trauma, a victim of physical abuse, worsening health conditions, new onset of health conditions, particularly in the behavioral health space, both mental health and substance use, are caused by the fact that the person is unstably housed. So there is just this really tight interwoven connection between homelessness and complex health conditions, both the onset of and the worsening of. Things that we know that people experiencing homelessness die on average at least 20 years earlier than their housed counterparts. So this is the data that we know. This is something, as with homelessness in general, we know it is an underdocumented reality. And so we know that it is just the complexities of navigating any health condition are much more they're intricate, they're more difficult when a person is unstably housed. So we know that the interface between homelessness and healthcare are incredibly intertwined, and that is a big reason why we say things like housing is healthcare, because of the ways in which simply being housed decreases the likelihood that somebody will die from the same exact health conditions than their unhoused counterpart. So housing really is healthcare. There's lots of complex reasons why that is true, but it is also just simply the fact that we know that being able to be out of the elements, being able to live alone or with additional supports, but not in congregate settings, and to decrease the risk of being a victim of crime and just having to live your private life in public spaces can prolong a person's life. So some of the ways in which homelessness and health are connected, we know that there's a lack of access to adequate nutrition and diets that might be directed by healthcare providers based on health conditions. So it is more difficult for somebody who is unstably housed to navigate and have access to these food, both because of the financial cost of many of food. We notice that food prices are constantly rising, but also just the ways in which food is accessible when you are unstably housed. If you are navigating housing as one of your primary needs, a person is likely accessing food that is being served or being prepared for larger quantities of people, whether that be in a shelter or in a meal program, or that they are purchasing food, but they don't have the access to store it. And so access to things like fresh fruit and vegetables, and even just foods that don't have preservatives is a lot more difficult to navigate when you don't have access to refrigeration and heating sources and cooking sources. Lack of the ability to store medication and any supplies. So things like clothing, clean clothing, very often things have to become disposable that would not be considered disposable for somebody who is housed, because they don't have a way to transport it or store it safely. Lack of transportation, meaning getting to places, having the choices that somebody else might have in order to be able to get around within their communities. This is particularly true in rural areas. Transportation is expensive in urban areas, but often there is some form of transportation infrastructure. Very often in more suburban or rural areas, there isn't even an option. As I discussed a little bit of that vulnerability to violence, if a person who is living on the streets or living in congregate areas, tensions between humans arise, and people who are struggling to survive often feel that desperation and feel a lack of safety, which may cause them to turn to violence or increase to exposure to violence. Environmental exposures. So we always say in any, certainly natural disaster, but in any evolving external environmental conditions, a person experiencing homelessness experiences it first, worst, and longest. So thinking of your routine flow of your climate area, regardless of where you live, there is still some fluctuation in your environment. And even in places where people are like, oh, it doesn't really get below below 60 where we are. That doesn't mean that there's not some forms of weather, whether that be rain, and also if you had rain, wind, sleet, in those areas that are not, we are looking at one of the largest winter storms to affect our country in a number of years. This weekend, I just read that it has the potential of impacting more than half of the entire contiguous United States population. That is a very big storm system. And just while not everybody will receive snow or ice from that, there will be ramifications on the environment. And somebody who is living outside or is not able to decide all the time when they are going inside, even if they are in a shelter, they don't have the complete control and autonomy over their decision making of where they get to be at any given time. They are more likely to be exposed to that. Lack of access to culturally appropriate care. This matters significantly. It impacts whether or not a person accesses care at all. It impacts whether or not the care is appropriate for them, is taking into consideration the realities of their culture. And health conditions we know have very different impacts in terms of prevalence within different communities and cultures. And if a person is unaware of those cultural differences, it can impact, while maybe not intentionally, but can have significant impact on a person's overall health outcomes. And then lack of consistent place to sleep. Anybody who has had children who has had sleepless nights, it is not the same as being outside or living in congregate areas, but you have a sense of exactly how your body functions when you have been without adequate sleep, even if it's for fun reasons. Maybe you've stayed out with friends, or you've had an opportunity to travel, and that travel resulted in not as much sleep as you would typically get. It has significant impact on your health. It has your impact on your body's ability to fight future health conditions, and can really contribute to a person's overall ability, their cognitive ability to navigate through the process of navigating all of these systems. When we are sleepless, our brains do not operate in the same way. So we know it is difficult for people to focus on big things like health and health management when those basic needs are in question. So Maslow's hierarchy of needs really exists and has been discussed for a really long time because it still applies. People need access to basic things: food, water, shelter, comfort, the ability to even just like long-term implications of, you might not be cold, but if you are wet, or exposure to too much sun or too much wind has real impacts on your overall physical well-being. Safety also is implicated, as we discussed, when somebody is experiencing homelessness. They are more likely to have to engage in activities that might make them less safe. They could just be exposed to traumatic events and violent events that are happening around them. And we know so often that the system of responding to homelessness even can create separations within families. So, in my career here in Baltimore, there have been times where young adults are not able to stay with their differing gendered siblings of a younger age. So when a child gets to a certain age, they may be separated based on their gender, which has lots of ramifications on the family system and the overall stress that everyone is going through. So these are compounding challenges that really HCHs and the HCH model is designed to try and support and to help minimize the impacts of. So when you think of a day without day without stable housing, a person is trying to figure out how to navigate all of these things. And things such as taking medications, accessing good nutrition, attending appointments often take a back seat. And that's really where the healthcare for the homeless model is designed to come into play. As I said, HCHs I think of at the intersection of homeless services and healthcare. They are healthcare providers. We are primary care, comprehensive healthcare providers, but healthcare for the homeless programs have very often are incredibly well versed and often embedded within the homeless service provider system within their communities. So what that looks like often is that these not only are do HCHs have partnerships within the healthcare system, so hospitals, specialty care, those sort of providers, but also shelters, meal programs, case management providers. They are versed and familiar with coordinated entry if they themselves are not putting people into your community's coordinated entry system. So they are very well versed in the homeless response system as well. HCH model is rooted in trauma-informed outreach and engagement. So, as I said, we provide not just primary care, but case management. We often look at a variety of models of care to meet those needs. So that can include mobile units. It can include street outreach teams, maybe even street medicine, where the comprehensive health care is provided right on the streets. Having positions such as community health workers, so these are people from the community serving the community that focus both on health needs and then utilizing peers who often look at behavioral health and housing support systems. Very often organizations have those positions as one and the same. Sometimes they are overlapped or they have both community health workers and outreach workers and peers. So we talked a little bit about the Consumer Advisory Board. These are essential for really knowing what the needs of the community are. HCHs shouldn't be designing their programs without it being informed by the people who will be accessing them. And so having both that Consumer Advisory Board that is a standalone board but also having that consumer representation on our boards. Integrated behavioral health and primary care. So HCHs have been practicing team-based care for decades. Before it was trendy and before it was a different reimbursement rate within the healthcare system, HCHs knew and were rooted in the fact that people had multifaceted needs and that our care is made better by having a variety of provider trainings at the table. And so they're all helping support an individual through whatever their goals are. The great thing about this and the way in which I've seen it apply across the country in the HCH model is that people don't have to access all of the services in order to reap the benefits of that integrated team. So just because a person might not choose to see a behavioral health provider doesn't mean that their medical provider isn't getting the support from and the learning from the collaborative approach from having that behavioral health provider on their team. And the HCH models do really include, again, as I said, we're not just looking at the health needs, but the big H health needs. So how housing comes into play in terms of reaching their health related goals. Thinking of things, knowing about the shelter systems, transitional housing, having other knowledge base of not just the healthcare system, but the social service system or the homeless service system within your community. Sorry, I forget how many. Sometimes I do these fun little graphics and then I forget how many there are. Let's see. So, healthcare for the homeless programs, as I said, really do have this wide array in which they might look within your community, but they are really rooted in the same core principles of providing that comprehensive care. So what makes an HCH different is this focus on access. So very often they are including multiple locations, going to people where they are. So not just having multiple locations, but also thinking about how they are accessing people that are not walking into those sites. That interdisciplinary care team we just discussed, they are working at that intersection of homelessness and healthcare. And then, as I said, the HCH programs, because of their funding stream, have that ability for that sliding scale to go down all the way down to zero, which makes them different than just your standard federally qualified health center. The core principles of the service delivery model, as I said, this isn't unique to HCHs, but it is core to who we are, and it has been for decades. So having person-centered care, making sure that the individual is involved within the decision making, informing what they get to decide what goals they want to work on, when they work on them, and what they want to prioritize. Having that multi-sidedness, focusing on the whole individual, that is means having these support and enabling services, which will be the last thing I leave you with, but being low barrier and serving as an interdisciplinary care team. So those enabling services that allow HCHs and federally qualified health centers to get that enhanced rate include things like case management, not just like one initial assessment, but ongoing treatment and facilitation in HCHs. This looks like a lot of housing navigation. So the case management support are particularly versed in the housing world, not just providing referrals, but navigating a person through referrals, providing that additional support, whether it be through a community health worker or a peer that is able to provide that support and often transportation assistance and maybe assistance in navigating and attending those appointments. So that is where all of these layers of enabling services come into play. Um, and then almost finally, just a quick overview. Hopefully you all are familiar with medical respite, but as I said, medical respite is one of the ways in which the HCH model is being delivered. And so these are post-acute care settings, so post-hospitalization typically for people who are too ill or frail to return to the streets or shelter or wherever they were living, but don't require hospital level of care. So this really came in the space of people were getting discharged from the hospital and very often cycling back through because the shelters were unable to provide the support that they needed, but they didn't really need to be in hospital level care. And I'll drop the NIMARC website. If you have a respite program and are looking for more information or are interested in this model, we have the incredible National Institute of Medical Respite that's part of the council. So, and then finally, really the work of HCH is to be a patient-centered approach to care that recognizes the impact of trauma, of homelessness, of the experiences of having to navigate these very large systems, and actively works to prevent re-traumatization and to promote recovery. So not just to be trauma informed, but to be healing centered. So trying to really focus on the reduction or elimination of potential negatives of a person without requiring them to engage in all of the services that someone else might say they would benefit from. So really being person-centered, almost, some might consider it to a fault. It is not to a fault, but to be focused exclusively on the individual's goals and recognize that they might be slightly different than what the care team would hope for them in that moment, but to recognize that it is all a possible path forward. And then I'm just going to leave you with the reminder to always ask about housing status. There is so much you can learn from this. It will inform your care plans for the individual, and it will come up or will impact your care, whether or not you ask about it. So the benefits of asking about it are that you can use it to inform the way in which you work with the individual to develop a realistic care plan for themselves. All right. I am going to hand it over to Sean.
Thank you, Katie, so much. Let me get in there and share my screen. Well, thank you everybody for being here. My name is Sean Marsden, and I am the Director of Street Medicine and Community Outreach at Fred Community Health, and we are an FQC that works and resides in the Denver metro area. So we have 10 clinics that kind of scatter from east to west, and we do all the things that Katie talked about. We do sliding fee scales. We see all ranges, so Medicaid, Medicare, some insurance, regular insurance, no insurance, migrant immigrants. We are non-reporters in our FQC, so we do see a lot of of the migrant population that comes through Colorado, and the large portion that came through earlier from Venezuela. We roughly saw probably 3 to 4 thousand as they came through Colorado, and we were one of these street medicine teams that was doing a lot of the medical outreach for about 105 tent encampments that were down at Elitch's. So we see our fair share. So again, this is what we come across. We do see all kind of genres of people in our clinics, and what makes us kind of unique in our street medicine program is that we have access to where we can send them to our clinics. We can get them to our brick and mortars if we need to, or if they want to. It's just depending on what their need is at that current moment at the time. And so quickly, how this kind of came about is 3 years ago, I was working as a school nurse for one of the largest high schools in here in Colorado, and I had got an offer to come to work for Stride. So it began as me just going to be a community health nurse inside of one of our clinics. And kind of through a reduction in force and a new change in our leadership, we found ourselves without what previously to our street medicine team was a healthcare and community team. So we had a nurse practitioner and medical assistant and one navigator that would go out and go a lot of brick and mortars. And when we restructured, we lost that. And luckily for us, our new CEO wanted to have an actual street medicine team because he was from Southern California, where USC was, and they have an incredible just street medicine program there. So when it happened, there would just happen to be a about 25 tent encampment, which was about 3 to 4 miles from one of the clinics I was at. And one day I just walked into the encampment and asked if they needed care. And kind of from that, it just spawned this incredible program that we have backing from our executive leadership team on. So it's difficult. As Katie had mentioned, there are just a lot of things that happen, and it's a very dynamic and diverse environment here in Colorado because of not just the political landscape, but what we're seeing county by county, city by city. So a lot of the areas that are around the city and county of Denver cut out all their sheltering, which means they don't do any more overnight shelters at night. So everything out west lost their sheltering, everything in the south lost their sheltering, and just recently Aurora was funded to build a navigation center, a regional navigation center. But up until that point, the City County Denver was the only entity that had overnight shelters. So there were 3 overnight shelters in Denver, and so a lot of people just didn't go. And so with that, we just became the only medical team that provided care in all 5 counties. And like I said, as I started, just started with just me in a backpack, and I just went out. And it happened to happen for about 2 weeks when I started doing it. Then I got a call from my CEO or new one, and he said, "Can we meet?" And when it happened, I honestly thought I was going to get fired because I didn't tell him that I was just doing this thing. We were just doing it. And after he and I sat down, he said, kind of, can you tell me what you've been doing? I was like, well, it depends on what you've heard. And he goes, well, what have you been doing? I'm like, again, what have you heard I've been doing? And then we just kind of laughed. And I was like, okay, maybe this is going to be, maybe this is going to be okay. And so I said, look, I don't know much about, CHCs because I don't come from this world. I retired from the military in 2013, and then I worked as a paramedic, and I went to nursing school. So it was just a different environment. And so when this came about, I said, I just thought we are supposed to be based in community. So if you're based in community, then why aren't we doing the community things? And he goes, well, what made you decide this? I'm like, well, if we have a clinic that's literally 4 miles from, if we have an encampment that's 4 miles from our clinic, why aren't we there? He's like, well, that's a very good question. He's like, well, why aren't we there? I was like, well, I don't know. That's why I went there. And again, we just kind of laughed, and he just kind of sat back in his chair, and I was like, oh, like here it comes. Here comes the termination. He's like, well, that's what I want. I was like, great. Tell me who you want me to turn it over to. I'll let them know kind of where we're going, what I'll be doing. He's like, nope. He's like, if you start it, he's like, you finish this. And at that time, roughly 3 years ago, I just kind of went, I sure. And then from there, we just built it. And it's been this amazing thing that's happened. It's been a blessing, but we have gotten to the point now where we can do all point of care testing in the field for STIs. So We can do hepatitis C, we can do HIV, we can do chlamydia and gonorrhea. We just recently kind of solidified a contract with Binks is the manufacturer, but they are the only entity right now in the nation that does point of care testing chlamydia and, chlamydia and gonorrhea for males through urine, and we were actually able to build that contract. So it's kind of changed the way that we've been able to treat people out in the field. Man, this clinically as a healthcare provider, we have all these things, right? We can do medicine in the field. We can take care of wounds. We can, get them behavioral health. We can get them to all these things, but if there's one thing I say that our team has learned over the past several years is that nothing is going to be, there is no better treatment than just seeing somebody as a human, that's sitting down next to them and just being present in the moment. In the beginning when this all first started, we were huge on trying to assess patients. Like, we need to assess when's the last time you ate? Do you have access to clean water? How often, do you have somewhere you use the facilities? All these things that we were trying to do, but you know, our population has been assessed to death. Every time it's an assessment, it's assessment, assessment. So we've learned that isn't really what it's about. It's really about just being present in the moment and seeing them as a human. So some of the best medicine that we've done is just listen. Over the years, we've got to the point where we've been able to sit down to someone and now it's just, hey man, tell me your story. Tell me your story, how this got to be. Because when you do that, when you take time to truly be present and to truly listen, they give you all the answers to your assessments. You get it. They'll say, well, I'm originally from Tennessee, and I came here because I was looking for a job. And you're just like, check, check, and I've been on the streets like 7 months. Check. It's all these things that you get. And if you just take time to listen, they all answer themselves, and as we all know, there is a clear gap between, an unhoused patient getting into the ER and then being seen, sometimes not being seen, and then just being discharged to the abyss. And so why aren't we trying to figure out how do we close that gap? How do we become that bridge between someone getting ready to be discharged from the ER back to the streets, or if they don't meet the criteria, how do we get them into a medical respite? And there aren't many medical respites here in City County, Denver. The Coalition for the Homeless has a very good respite program, a recuperative program, but outside of them, there aren't many. So as we were going to build this program, and after my CEO Santos Vera, he said go and build. So I would meet with him, if not every week, every other week, and he said, "Where are you at? What are your challenges? What do you need? How do we make this a thing for our program?" So he and I sat down and we said, "Okay, what is it that we do?" Right? Yes, we do a lot of things where we see the marginalized, that we see, that's 200% the poverty line and below. But how do we build our program in a way that not just clearly defines our mission and our values, but gets back to being the grassroots of community, because that's where it's at. And that's how we started to build a program. It was like, do we see ourselves as an extension of primary care? In a sense, yes, we do, because we are able to take our medicine to the people, right? We go out there and we take everything that we do and we go to the people. But then we also realize too that we need to be that bridge in between our patients and where they are, whether it's an encampment, whether it's an underpass, whether it's a car, whether it's a shelter. How do we bridge that between, yes, I can get to a clinic, or no, I can't, and all I have is what I'm here. So that is where we took that early build and said, okay, this is how we build our program. And so as this grew, it went from me and to meeting with my ELT and like, okay, we think you need some help. And I was like, I really need some help because I really don't know what I'm doing. I'm just seeing people and doing what we can. He goes, well, why don't we get you a medical assistant? And I was like, great, let's get a medical assistant. So then we sat down like, well, what do we do? Well, what are we doing? How do we build? And so we just continually saw people. Then we're like, wow, we got to the point where as we started to see people, we realized that there was just much more than we needed to do, that it just wasn't medicine. It's like, how do we resource people? And like, wow, how do we get people access to Medicaid or Medicare when they don't have it? So as we kind of saw these gaps in where we were, man, it was just perfect that our ELT was like, okay, we're gonna get that. Okay, let's work on it. Like, how do we make this thing happen? You know, so if it wasn't having the backing and support of your C-suite, a lot of these things won't happen. So we were lucky enough that, our CEO is vested in our program. He understands street medicine more than what I thought he would, because of where he came from. So he understands that. And as this program built and we got to the point we're at now, there are always clear defining roles. Just like it says, I can do a lot of assessments. I can do a lot of the wound care. I can do a lot of the escalation and de-escalation techniques. And there are things that the medical system does, but at the end of the day, we all do everything that we can for that patient in the moment, because that's just where we live. It's something that I can't do that MA does, and great that MA does it. Yes, do we have policy and procedures? Do we have standing orders for each of us? Yes, we absolutely do. But at the end of the day, it's like, what can we do to make this flow work, that we can give this patient all we can in the moment? Because as you guys know, sometimes all we have is that 5 minute window with that patient. It's like they either don't want to be there, or we only have 5 minutes. They're going to be willing to talk before we lose them. So we do everything we can in that moment. This isn't a job everybody wants. I think we all know this isn't a job that people just they do or they don't want to do. I will say that the struggle for us as we built this program is that we would have people apply, and then I would call and I reach out to them. I'm like, "Hey, did you really read that job description?" They're like, "Yeah, I did." I'm like, "But did you really read it?" And then they were like, "Well, what do you mean?" So then I would tell them, "Look, this is what we do." And then about 85% of the applicants that applied to this position were like, "I'm sorry, but no, I don't want that." And so as we went through and as we really started to find, like, what is it that we look for, and what is it that I look for, when interviewing someone, because it's easy to go through those five standard questions everybody does. Like, tell me a time when you had, confrontation with a coworker or a boss, whatever, and everybody can just say, well, I did this or I did that. So what we turn to is I tell all our applicants, I'm like, look, I only have one question for you. And the question I have is like, at the core of who you are, outside of needing a job for, financial security, all these things and has those market needs, tell me the one thing it is that drives you as a person. What is it deep down inside that makes you do the job you want to do? And it's not that, I'm rigid or, I'm jaded about it, but if they can't answer within the first couple seconds, at 10, 15 seconds, well, I do this because of this, because I have this or I have that. We're like, okay, we're going to move on, because it's that driving thing that's deep inside of you that you just know that's there. Even if people would say, what, I don't know what it is, but there's just something that's deep inside me that makes me want to do this. That's where I'm like, I'm sold. Because outside of everything else, because we can all teach skills, right? We can teach you the job. We can teach you, administrative how to do a job. But what we can't ever teach is how to treat somebody as a human, as to be compassionate, and to just be in the moment. You can't teach those things. Either you can do them, or you just can't. And it's not that it's against the person. It's not that it's a bad thing, but either you do them or you can't. And that was a challenge we faced and that we still continually face now. And when we get to that kind of level of things and finding what team members work, it's just, who are you as a person? Because that's what drives the most out of anything else. You can be the greatest, ER nurse. You could be the greatest public health nurse, but if you can't set down the cell phone when you're out there on the streets and put it away and just be with that person in the moment and just sit and talk, like, man, just tell me your story, man. Tell me how you got to be where you are. And if you can't say, good morning, sir, or good morning, ma'am, because those three words change that entire conversation when you meet them. It's like, wow, they called me sir, they called me ma'am, and it wasn't just, hey, how are you? But you're taking that second to say, I see you. Kind of like the Avatar movie, like, I see you. It's that same concept. Like, man, I see you as a person, and we're gonna move forward only if we see each other that way. And now my screen is frozen. Let's see if I can change this. And
And Sean, we have about 10 minutes left in the session,
Yep.
just for your pacing.
Yeah. Let me got frozen on me. So we kind of like we went through, we our C-suite helped us build around this. So we built the backbone, we built operational pieces of this, the data, so it's all in there. So we track everything that we do. For the encounters where we have a provider visit, then those are all managed in our EHR through Epic. If we don't, then we have a big Excel spreadsheet that we go through. So if it's just an encounter with a patient, where we meet them, we track if they give us their name, we'll take their name, then we give kind of just cross streets where they are because we pin all those on a map so we can see and follow those patients as we get around. In the last probably 6 weeks, we were invited to be the medical entity for Aurora's Navigation Center, Regional Navigation Center, which was huge for us because they have a tiered network there. So they have a tier one, which is about 300 cots that they have that they just do overnight sheltering for. Then they have a tier two and a tier three based on how well they work. And then tier two kind of puts them in a smaller group setting, and tier three takes them just into a hotel room by themselves. It was almost like they have their own room. But as we got into this navigation center, the first day I was there, it was a humbling moment for me because I walked in and there was roughly about 150 people there. And as I looked around, I only recognized like 5 faces or 6 faces. And in that instant, I thought, man, I don't know nobody. I know no one in here. And then I sat back, it's like, well, for the past 3 years, have I been doing my job? Because I don't know anybody here. Have I mean, we've been on the streets, but I don't recognize people here. And it dawned on me that there's an entire another subset that I have not engaged in, just how happened to be these people there. So it was humbling, but it really put things in perspective. Like, wow, there are notches, there are crevices, there are cracks here that we just haven't touched, that we have not been able to step into. And luckily for us, it got to the point where we got to see them now. So in the first 5 weeks we were there, we had 220 visits into our small clinic, and out of those 220 visits, we had 87 provider visits. So we're actually able to reach an entire another population that we weren't able to reach before. About 2 weeks ago, we were asked to help build a medical respite. It'll be between a 15 and 20 bed respite there. So we're working out the final steps into making this happen, but we will actually be that provider for that medical respite. So it's something different and something new for us, but we'll be actually able to provide the care that's needed for these patients. And we've been working with our local hospitals to do ER discharge planning and inpatient planning, discharge planning into the medical respites themselves. So out of the three big hospitals there, each of them so far have kind of verbally said that they will take 1 to 2 beds, if not more. So hopefully, we'll be able to close the loop on these patients that are being seen. And if I was to tell you anything, it's just you just start with people. It really is just start with people. See people as humans, and then just build from there. And if you if you don't have leadership in your C-suite that's engaged, make them engaged. And if they don't want to be engaged, then find the avenues that will be engaging for them. And but I will say, if there's anything that you can give them, it's the stories. We can track data, we can see data from everywhere. You can follow data into data points, and that's how you can help build this program when it comes down to the financial stability of a program. But there's nothing better to tell somebody than a story. And if you get to the point where you can tell them a story about how somebody came to be, that's where you need to lead. And these are just the wish I knew. I wish I knew early on how to see people as humans before I got into this, before trying to assess, before trying to figure out why, before stereotype if someone's in context of being unhoused. I just wish I would have saw it as a human first. And quickly leave off. I only have like 3 minutes, but about 3 weeks ago, I we were out doing some street outreach, and there was a gentleman by a fence. And I went over to him and I just said, "Hey, just we're doing some street outreach." And he goes, "I don't need anything." I'm like, cool. I'm like, well, do you mind if I sit down? He's like, suit yourself. I'm like, okay. And then I sat down and I sat there for about 10 minutes and I just, I didn't say a word. I looked over at him once or twice and he looked over at me and I was like, okay, I'm going to sit here. I'm like, hey, do you mind if I ask your name? He told me his name. I'm like, cool. Okay. And you just get to feel like they don't want something. They don't need anything. And I just sat there, like I said, for about 10 minutes and I go, hey man, it was good to sit with you and I'll see you later. And as I was leaving, he's like, hey, and he got up and he goes, hey man, I just want to say thanks. And I was like, for what? I didn't do anything. He's like, no, just, man, thanks for seeing me. I'm like, what do you mean? He's like, thanks for just seeing me, as a person. And I was like, hey, this is it. This is what we do. And he's like, I just want to say thank you because if it wasn't for you guys being here and just seeing me, he goes, I probably wouldn't be here. I go, what do you mean? He's like, before you guys came, he goes, I was seriously thinking about just not being here anymore. And that was a solidifying moment to understanding why we do what we do. Outside of everything else, it's seeing people as humans because in the moment when you're with that person, that may be it. That may be the moment that they need. So there's anything, take the time to see somebody as a human. Because at the end of the day, that's all we really have. Like I said, we went from one person in a backpack to two complete teams. We have over 55 partners that we work with now in Denver Metro. And I will just say it's always one step forward, and sometimes 15 steps back. But if you fail, just keep failing forward because it will come in time. And that's all I have.
Great. Thank you so much, Sean. And thank you, Katie, also for providing that overview in the beginning. We have about 3 minutes left, but I did want to get at this one question we have down in the chat. Kendra asked, but this is a question for you, Sean, that she heard you said you were in the military and was wondering if your time in the military helped prepare you for this work, and if so, how? Wanted to know more about like the hard skills, relationship skills, and values. And then were there any things you had to unlearn in order to do the work?
It did. I retired in 2013. I did 3 tours in Iraq. And if there's one thing it did, it taught me, that you have to view everything at face value for what it is. You have to get away from stereotypes about people, because there were some very difficult situations and there were some very hostile situations when we were overseas. But when you unlearn those things, when you really step back and take away the threat, because everyone isn't a threat. Not everyone you come across for me is a threat, but you still have to assess and you dig and you figure things out. And I will be very vulnerable and say that, after my third tour, when I got back, I had 5 years of therapy for PTSD, just for things that had happened from being overseas and trying to unlearn behaviors. Unlearn behaviors about the paranoia. Always like, I locked my door, but I know I locked it, but I'm gonna go check it again because I don't know. And looking everywhere. Like I would walk in a restaurant and be like, I know there are 3 exits. I know which one's closest to me, and I know which one, if there's a threat, I know where it's going to come from. But you unlearn those behaviors. Like they're there, but you unlearn them, But the other things about teams, there's a thing, it's the team that's transferred over from the military into the job I do now. It's my team. Nothing I could ever do in my job or any job I could do without my team. And it's a team that makes it. I'm a person, but as a team, man, you can be unstoppable. Kind of cliche-ish, but you are. If you have a really good team that you can depend upon, that knows your weaknesses, that knows your failures, your flaws, and they can pick up your slack for you without even you have to say a word or you can just walk in when they be like, I just don't have it today. And the first thing your team says is, I got you. I got you. We'll get through this. That's the important piece.